Dear friends, my second talk is about vertebral body tethering technique for idiopathic scoliosis treatment. As we are the orthopedic surgeons, we are very well aware of using similar technique in extremity deformity correction, which we do epiphysiodesis, especially in the knee deformities. We use the same type of surgery. As you can see here, that the knee X-spine deformity is corrected very well with the same technique. In this drawing, you will see that if you achieve to stop the growing on the convex side and the concave side growing continues at the end, that you may have a chance to correct the deformity. And for more than a decade, maybe 20 years, I know from SRS meetings that there were several studies and attempts to use this technique to correct the spinal deformities. But at that time, because of the technical reasons, it cannot be achieve good correction rates. And many surgeons use vertebral body staplers and try to correct the, especially the juvenile early adolescent idiopathic scoliosis treatment. So simply the tether compresses the convex vertebral growth plates, inhibiting their growth while allowing the concave growth plates to grow. So this is an article that you will see coming from, it's an original article from Eurospine, 2015, and they use the system, this method, in 32 patients with good results, especially in immature adolescent idiopathic scoliosis with more than 50% flexibility. And this is again the article from Spine. They use the same system for growth modulation to obtain the progressive scoliotic correction. And they had 11 patients with COP angle is around 44 degrees, and it corrected to 20 degrees. And 2 patients returned to operating room in 2 years. And this is again an article from 2015, Eurospine. These are the early results of vertebral body tethering surgery. And they had 32 patients, and the curve correction was around 50%. So again, they looked to safety and efficacy of vertebral body tethering in the treatment of idiopathic scoliosis. And this is one of the recent articles published in Bone and Joint Journal, 2020, with 57 patients with the mean follow-up period of 40 months. And 31 to 81 degree curve corrected to 0 to 57 degree, and clinical success rate was 77%, which they accepted as a success rate, having the post-operative correction less than 35 degree. So they had 28% of complication and around 16% unplanned revision surgery. So again, from 2022, indication, surgical technique, and systematic review was published in Journal of Clinical Medicine, and they accepted as a growth modulating system. And they had again 18% of complication, and 15% patient need reoperation, and 5% of these patients need to convert it to the posterior spinal instrumentation and fusion. So anterior vertebral body tethering Again, 69 patients with minimum 2 years follow-up. Mean major corrections around 50%. Tether breakage is about 27%, and tethered breakage is higher in thoracal lumbar curves, and double course may not be protective. So another article is coming from Journal of Bone and Joint Surgery with 29 patients. In this article, tethered breakage was around 48%. 2 patients underwent posterior surgery, and 4 patients had tethered revision. So when we compare the vertebral body tethering with posterior instrumentation in immature patients, standard 3-4 patients with COP angle less than 35 degrees on 3-month imaging was associated with success at 2 years follow-up. So the success is accepted as the curve magnitude after the surgery is less than 35 degrees. So within 26 patients, 12 patients vertebral body tethering showed curve improvement over time. Tether breakage was again 19%, and growth continued at T1, T11 level with mean 1 centimeter. This is the largest series, 163 VBT procedures, 14 needed unplanned surgery, and 11% converted to posterior instrumentation. This is again 112 cases with 1 screw and 1 rope. 22% of patients had complications. 32% of them had tether breakage. Patients had 38% repump correction, and 71% cases end up less than 35 degree curve. When we look at the pulmonary complications, 140 patients, 14 experienced a pulmonary complication, and 13 patients required invasive treatment. So now let me present my cases that I do, and let me tell you that how I do vertebral body tethering surgery and which cases I prefer to do it. So mainly I prefer to do it in lumbar curves or thoracolumbar curves. I prefer mostly immature patients. And also I would like to have the patient have the flexibility more than 50%. So this is 14 years old male patient, and you will see that preoperative and postoperative X-rays, very nice correction. I always use double rope, not a single rope. So I use 2 screws in one vertebral body. And this is 10 years old female, again with lumbar curve. And you will see again a very nice correction with this is the preoperative picture during the surgery, and this is the 2 years follow-up. So this is again 11 years old female. I also prefer to do a hybrid surgery to correct the thoracal curve with posterior instrumentation and perform the VBT at the lumbar curve. So this is again a case of hybrid surgery. And you will see that again, a 13 years old female with lumbar curve. I did hybrid surgery because if I do only the lumbar curve correction, then the shoulder imbalance will remain. So I solved the shoulder imbalance problem with thoracic posterior instrumentation and very nice correction of the lumbar curve. This is 12 years old female with thoracic and lumbar curve, and I did thoracic and lumbar vertebral body tethering surgery, and this is the post-operative result. So I would like to thank you again, and we will have a chance to see each other in the future. Thank you.